Hello guys, welcome again to Aagaaz the Revival. This is the Women Empowerment Month. In my last podcast, we talked with Master Instructor Bobby Trentafilo, emphasizing on women fitness. And today we are talking about women health. Guys, improving women's health strengthens women's economical empowerment. I strongly believe that access to information on reproductive and sexual health is crucial to the bodily health and bodily integrity of women and girls, and bodily education has the potential to increase women's chances of pursuing higher life goals and breaking out of poor lifestyle methods, making progress toward the gender equality. How can we speak about empowering women without providing all the necessary information and conditions to improve and keep in control their health? Today, I invited Dr. Rupinder Toor, Chief Medical Officer and founder of Project Empower Her. Hi, Dr. Rupinder. How are you doing this evening?
I'm well, Deepshika. How are you?
Very good, very good. Long time. We are on the screen again.
Nice to see the full face without the mask, right?
Yeah, thank you. Yes, absolutely. It's a great month to talk about women's health and empowerment.
Yes.
And thanks for being with us tonight and find some time from your very busy schedule. Today, we'll be talking about health issues of women at any age. But before asking you details and the importance about these, I would like to ask you, this question always, gives me a little itch that I feel like that women live longer and have more unhealthy years than aging than men. Why it's like that?
I think women, we're biologically wired to look after everybody else. And so oftentimes I think women put themselves last, so they look after everybody else. And then finally, when they get time to look after themselves. But obviously, if you think about it, if you're at your best, then you can be your best as a mother, as a sister, as a wife, whatever, roles you might be playing. The other thing I think that people or women should look forward to is when they do surveys and stuff, they find the happiest time for women is actually sort of after the age of 50. And that makes sense because when you think about, a lot of your responsibilities are starting to dwindle, your children have grown, they're maybe moving out, and you get to actually focus on yourself again. And I feel like women at that point also have had a lot of life experience. They've also come to know who they are as people, and they've sort of come into themselves. And so, there is a better time coming. I feel like when the kids are young and you're in the midst of your career and, everything is really busy and you're getting pulled in so many directions, it's actually really normal to actually not be very happy during those times because it's very stressful, right? But there is light at the end of the tunnel, right? And I don't think necessarily we need to think of aging as declining, right? The way I see it, I think age is just you're becoming more of who you are. So you're just becoming more and more and more. And that's a beautiful thing, right? So I think it's lovely when you meet women who are a little bit older, have this beautiful life experience, can sit back and reflect and also have the time to look after themselves as well.
Yeah. So I think to live that kind of life, at the older ages, look beautiful and fit or healthy. So there are a few things that usually women ignore. So we'll be talking about those today. My first question would be, what is screening?
Right. So screening is something that may be a little bit of a foreign concept for a lot of people, depending on maybe, which countries you were raised in and what the healthcare system was like. But screening basically means that you're going to go and see the doctor when you're feeling well, right? So oftentimes we think of, okay, when you're sick, you go to the doctor and they give you some medicine or whatever, and you get better. But we don't often think about going to the doctor when we're feeling fine, when we have nothing wrong with us. But screening is really a way for us to check for certain types of medical conditions before they actually worsen. And if we can check for them before, oftentimes they're much easier to treat and manage. And we can't screen for all of the conditions, obviously, that you could be diagnosed with, but there are a few kind of main ones for women to sort of keep in mind because they can make a difference, and screening is relatively easy.
And what is pap smear?
Yeah, so pap smear is one of those examples of a test that it's a great screening sort of success story. So it is a way to screen for cancer of the cervix. So if you know, the cervix is just the bottom of the uterus where normally you would carry a baby. And so the Pap test is basically just kind of taking a sample of those cells, and they're looking for cells that look mildly abnormal way before they actually get to the cancer stage. We know cervical cancer is very slow growing. It can take 10 to 15 years to develop. And so if we catch it early, oftentimes they can manage it early as well. So they can, if they see any cells that look abnormal, they can treat them, they can laser them, they can freeze them off. They can essentially get rid of them, and so that they're not going to progress into a cancer state.
And what is the right age for women to start doing their Pap smears?
Yeah, and this one does keep changing. Deepshika, like I have been in practice for over 20 years, and that age has sort of changed as we get more evidence and more clinical trials. But at current in Alberta right now, we're saying to start at age 25 or 3 years after your first sexual intercourse, whichever comes later. So that means that we don't necessarily screen women under 25, but at 25 we ask and see if they have been sexually active for at least 3 years. We'll go ahead and start their screening program. Otherwise, we'll wait until they've actually been 3 years after their first sexual intercourse.
And how often women should have a Pap smear?
Yeah, so that's changed as well. So it used to be annually every year, but we found that, maybe we weren't really, we could actually have the interval for a little bit longer and still sort of make good gains and good success. So currently they're saying at starting at age 25, let's say, and doing it every 3 years until the age of 69, right? So at age 69, if you've been going regularly, you've had at least, let's say, 3 normal Pap smears in the previous 10 years, then you can discontinue Pap screening at that point.
And as talking about cervical cancer, is there anything else women can do to reduce the risk of cancer, cervical cancer?
Yeah, so Pap smear is just one way to screen. Obviously it's a test, so it may not pick up all cancers, especially aggressive ones, or sometimes there can be false negatives with tests as well. So really, when you look at what sort of leads to cervical cancer, we know that the human papillomavirus is involved, almost like probably 99% of the time. And the human papillomavirus is sexually transmitted. And so you can actually get vaccinated against that. So this is something that's relatively new. It maybe came sort of around maybe 2005 or so. And if you notice in a lot of the public programs, boys and girls in grade 5 are being vaccinated, and that is being paid through the public sort of purse, right? So the government is paying for those people. In Alberta, currently right now, 26 and under women can get the HPV vaccination done through the public service as well. It doesn't mean that if you're older than that, you're not going to benefit from it. It's just the government can only pay for so many people, so they've just kind of focused on the younger people. But it's 3 shots over 6 months, and if you get all 3 shots, it will protect you against 90% of the strains that can lead to cervical cancer and 90% of the strains that can lead to genital warts. So it's something to consider as another way to protect yourself against cervical cancer. The downside is the cost. The shots can cost up to $200 per shot, so about $600. If you have insurance coverage, oftentimes it will cover for the 80% coverage that you might have. But even if you have the budget to pay for it on its own, it's sort of an investment in your health. So something that I do certainly have a conversation with all women about, and see if they'd be interested in adding that protection for themselves.
And another thing is breast cancer.
Yes.
And it's very popular. Can women be screened for breast cancer too?
Yeah, so again, our sort of thinking around screening for breast cancer is evolving. And so we certainly know that women age 50 and over, the evidence is strong that, or it's good evidence that, screening works. And so we do recommend women 50 and over, getting a mammogram done, which is an x-ray of the breast every 2 to 3 years. And again, up to maybe the age of 75 or until whenever they want to discontinue that. And in their 40s, it's a little bit more controversial whether it's actually useful or not, right? And so we know that the incidence of breast cancer is lower for women in their 40s, but the women who do tend to get it, it tends to be a little bit more aggressive. The issue with women in their 40s is really around a lot of the false positives. So sometimes when we start testing, we start to pick up things, we start to do biopsies and further sort of, interventions, which can make a woman feel quite unhealthy. And then they turn out that everything is fine. And so they did find that the false negative rates can be a little bit higher for women in their 40s. So for me, when I talk to my patients, I sort of say, look, in your 40s, it's kind of optional. Like if you'd like to go, you can certainly go. Just keep in mind, there may be this false sort of positive testing that can happen. We also look at what is their personal risk factor. So have they had, breast cancer before? Have they had family members who've had breast cancer? If there's something that maybe puts them at higher risk, then maybe we would want to start screening them a little bit earlier in their 40s. And if you are going to do it in your 40s, we do recommend every year, just like I said, because it's a little bit more aggressive. So they want to have a little bit of a tighter interval on those ones.
And how often should women go for mammograms in general?
So in general, 50 and over every 2 to 3 years seems to be adequate. And then if they choose to go in their 40s, every year.
And is there any time that women can stop doing mammogram?
Yeah, so as I was mentioning, maybe age 75, but they could certainly go longer than that if they wanted. There really isn't a hard end on that. And we can talk a little bit about breast self-exam and clinical breast exam as well. So again, that's something that, in the past had really been recommended. And when they really looked at the evidence for that, they found that women necessarily didn't find their own breast lumps during sort of regularly scheduled breast exams that, if we tell you to do it every single month, or whatever, that when they did tend to find it, it tended to be just during just an episodic check. Maybe they're in the shower and they were checking. And so again, as doctors now, we're saying that we don't have to necessarily prescribe people to do a scheduled breast exam, but they should just be breast aware, right? So they should just be aware of their skin, any dimpling, any puckering, and then, occasionally kind of checking to see if they feel any lumps or they're having any pain anywhere. The clinical breast exam, just the one that you do with the doctor as well. That also, they looked at the evidence to see, does that actually help and does it actually save lives for that time that it's kind of invested in there? And they found that in countries where we have access to mammograms, the clinical breast exam probably doesn't add a whole lot more. And so again, that is kind of optional. I let my patients know if they want me to do a breast exam, I can, but it really often doesn't really pick up a whole lot more than what the mammogram might. But the clinical breast exam, having it done by a health professional, might be useful in countries where they don't have access to mammograms.
Yeah, very nice. And another important thing is, it's a women's right too about birth control. And we are hearing a lot about long-acting birth control. What is that?
Yeah, so birth control, the way I see it, it's a public health issue, right? And we can compare it to maybe, we're talking right now during the COVID pandemic, but 70% of the population is at risk for an unplanned pregnancy. So that means 70% of the population is having sex, but not actually wanting pregnancy. And if we don't do anything to protect women against that, we know that the consequences are going to be significant, right? Having a pregnancy when you don't want it is life-changing, right? Whether you choose to keep that pregnancy or not. And if women don't take any birth control, we know that they are expected to have 10 to 15 pregnancies in their lifetime. And if you're having that many pregnancies, you're not doing much else. You're not going to be able to, focus on your career or, just other things that you might want to sort of do for yourself in your life. So birth control has really changed lives. I could talk the whole podcast about it. You certainly know the women's liberation movement that happened in the 1960s. It wasn't by accident that it happened then, because the birth control pill came out in 1960. And so it was the science and technology which really laid the groundwork for the social change. So so birth control has only been around for, maybe 40 to 50 years, where it's been kind of, pretty successful. Even legislation, it was illegal to talk about birth control in Canada up until 1969. So for me to you and talk about this in a public setting, I could have gone to jail, Deepshika, and I would have taken you with me for sure.
You'll have a nice time there.
Yeah. So anyway, So these days, in the last, 10 or 15 years, there's been a real shift. And what we do now is we get really excited about what we call long-acting forms of birth control. So those are forms of birth control where you do something once and it gives you birth control for an extended period of time. So at least a year or more. And because you don't have to do it every day, they are over 99% effective. So those include things like the copper IUD, the hormonal IUD, and there's also a new subdermal implant, which is also a long-acting form of birth control. It's available in Canada.
And when is the right time? When should women consider long-acting birth control?
So really, you just have to ask yourself two questions. First one is, when do you actually want to be pregnant? And the second question is, how important is it for you not to be pregnant until you actually want to be? And women fall into two camps. So there's some women who sort of say, well, you know what, I want to get pregnant in a year. And if I got pregnant sooner, it's not really a big deal to me. And then there's the other camp of women who sort of say, I don't want to be pregnant for at least a year or more, or I never want to be pregnant. And it's really important for me not to be pregnant. Those women would be really well suited for long-acting forms of birth control.
And what type of long-acting birth controls are available in Canada?
Yeah, so I talked about the three. So two of them are IUDs. IUDs are small devices. They're about the second knuckle on your pinky finger, and they're in a T shape. The copper IUD has no medication at all. So it's just copper wire that's wound around the stem that basically acts like a spermicide. It just changes how the sperm can move. If they can't swim to the egg, you don't get pregnant. So they're like 99.2% effective. They're very cost effective. They're only costing around maybe $60 to $80, and they can last 5 to 12 years. So from a cost perspective, they're excellent, but they can sometimes lead to heavier, crampier periods, which some women may not like. There is the medicated IUD. So that one does have a little bit of progesterone that gets released just locally inside the uterus. So it doesn't actually go into the bloodstream. It stays concentrated and localized in the uterus itself. And it just does two things. It makes a plug, which blocks the sperm. You get 99.8% protection against pregnancy. And then the medicine also really thins out the blood lining. So periods tend to be much lighter. So 80 to 95% less bleeding than what you'd normally get. A lot of women love that type of birth, that option, because it takes the fear of pregnancy off their plate. And it also takes, dealing with your periods. You don't have to deal with this heavy bleed every month off your plate as well. That one's about $370 in Canada, and it lasts about 5 years. And then the third long-acting birth control option is relatively new to Canada. It came on the market in August of 2020. So it's a small rod about the size of a matchstick, and it's placed under the arm, and it's got a little bit of progesterone that does get released into the body. So you could get some hormonal side effects, similar to maybe how you feel like just before your own period. You can get some irregular bleeding and spotting, but most women bleed less amounts, less often. And there can be a little bit of weight gain. That one is $350, and it's good for 3 years. And it is 99.95% effective protecting against pregnancy. So I can't guarantee you anything better than that. That's probably the top sort of, but there are gold stars of birth control.
Right. As you mentioned, a few side effects of these. So these side effects are long-term side effects. They will always stay with that, or they are just temporary?
Just while you're using that form of contraception. So let's say for the copper IUDs, your periods could be heavier and crampier. As soon as it comes out, you'll go back to your normal again.
Okay. And now the most important thing, and especially our teenager girls, what is sexually transmitted infections?
Yeah, so, not everybody realizes that, when you're having sex, it's actually also a way to transmit certain types of diseases, right? Some of these diseases can be more just kind of, bothersome. Maybe they give you a little bit of discharge and, some local symptoms. So that can be things like chlamydia and gonorrhea. If they're left untreated, those could sometimes develop into pelvic infections and lead to things like infertility issues. But there's also, diseases that can get transferred through sex. So things like HIV, syphilis, hepatitis, and those ones can be a little bit more serious. So it's always important to try and sort of, consider the fact that you could sort of spread infections through sexual activity. So it's important to use things like condoms to help sort of minimize and, maybe limit your sexual partner. So you're limiting how much exposure you have. There is some vaccination. So we talked about the HPV vaccine, which can protect you against one type of sexually transmitted infection. You can also get the hepatitis B vaccine, which will protect you against hepatitis B transfer that could happen through sexual contact as well.
And how can women be tested for sexually transmitted diseases?
Yeah, so things like chlamydia and gonorrhea can be tested either through a vaginal swab or through urine testing. And then if women wanted to be checked for things like HIV, syphilis, hepatitis, those ones would have to be done through blood testing.
Mm-hmm. And last but not the least, menopause. There are lots of myths, lots of things around about menopause. So just tell something about menopause.
Well, the first thing we have to keep in mind is that women actually did not live past menopause until about the early 1900s, right? So this is, again, something new for us in the past 100 years that women have even experienced and had, longevity in life past menopause. So the theory is as we get older, our bodies require, some energy, and we start to shut down some non-vital types of organ systems. And basically menopause is the end of fertility. So that means that when a woman's gone through menopause, she's no longer able to get pregnant. So basically the ovaries start to shut down, but it's not like a light switch. It's not like one day they're working and next day they stop. There is a little bit of sort of, like normally you would have nice sort of waves, you get your period, your hormones go up and down. And what happens in menopause before everything shuts down is you start to spike and you start to go all over the place. And so it's a really tough time for women because everyone's experience is quite different. And, a lot of the things that they experience and sort of feel in their bodies can be quite different as well. But the most common thing, obviously, is your periods will get affected, right? Your periods sometimes will stop coming as often. You might start to notice that they'll come after several months. Some women start to bleed a lot. But to officially be diagnosed as postmenopause means you have not had a period in a year. So that if you reach a year with no bleeding, you are menopausal. You should never bleed again. And if you do bleed, you should go see your doctor. But we know that time when you transition from, ovulating and sort of, producing or releasing that egg every month to shutting down, there's lots of other symptoms. And so some of the ones women talk about is what I call above the waist symptoms. So those are the things that we talk about: hot flashing, night sweats, maybe some body aches, maybe some trouble sleeping. And because you're not sleeping now, your mood might be off, might be more irritable. And those things are fairly common in that transition. There's also what I call sort of, below the waist symptoms that women don't often talk about. So that would sort of include things like, vaginal dryness, irritation, maybe pain with sex, and similar sort of symptoms in the bladder. So frequent urination, sort of irritability, maybe even some burning when you pee. And that often can happen because now the estrogen levels have dropped and the mucosa that's sort of inside the vagina there can get kind of thinned out. It becomes drier and it becomes less elastic. And so those things can contribute to that dryness or to that pain in sex. The good news is, it is very common. Women don't often talk about it. Those symptoms can actually get worse with time, whereas the things like the hot flashing, night sweats tend to get better. You kind of go through a little phase and then it settles down. But those local vaginal symptoms can actually get more and more pronounced the longer you go from menopause. But the good news is that there is treatment, and the treatment is fairly simple. We can either use things like, you can get moisturizers for your skin on the outside. There's moisturizers you could get for the inside of the vagina as well. And then you can also use just a little bit of what we call micro local estrogen treatment, where you would take a little bit of estrogen and put it in the vagina, and it gets absorbed by the cells that are there. Not much will get into your bloodstream, into your serum level, so you don't have to worry about all the other things we have to consider sometimes when you take oral estrogen. But that can actually really improve sort of the condition of that, those tissues inside the vagina, and then it can make sort of, intercourse a little bit more comfortable. Because sometimes when, we were saying that women at that time, 50 and over, are actually, maybe having a little bit more time, people don't realize sometimes that as people get older, sometimes sexual activity can actually increase, right? When the kids have gotten older and they're leaving home. And that discomfort can sometimes then sort of become a little bit of a relationship issue, because, you want to be close with your partner, but it's feeling uncomfortable and painful. But like I said, people just don't talk about it. It's very common and it is very easy to treat.
And, usually menopause starts, perimenopausal starts around 45 or something. So what is how women can prepare themselves? Should they go to see their gynecologist at that time? Or as you said, sometimes women, they ignore some of the things. So how they can prepare, and they should talk and more vocal with their doctor?
Yeah, so I think it's important just to be aware of the time frame. So the average age of menopause in Canada is age 51. So that means at 51, half the women have stopped having their periods for a year, but the other half are still having them, right? So just having a sense of timing, sometimes when your mother or your sisters went through menopause can also be a little bit indicative of when you might go through menopause. But like you mentioned, it is sort of typically into the late 40s there, early 50s. And you know what? It's all the same stuff. As a doctor, I can only tell you, right? So it's all about, getting good rest, right? Making sure you're sleeping, right? Your diet is really important, making sure you're eating healthy. Meditation is really important, right? Just to sort of for your emotional and mental health. And then obviously exercise, just to keep yourself an ideal body weight. Obviously, sometimes when you're carrying around extra fat or extra weight, that can also contribute to how women sort of go through menopause, because believe it or not, fat tissue also contains a little bit of hormones sometimes, and that can kind of contribute as well. So just do all of your basic things, know about the general time frame, know about the symptoms. And if you're having symptoms that are affecting your function, so you, like, let's say you're having lots of hot flashing where you're just having trouble functioning in your day, you can't, attend meetings or go to work or whatever, just talk to your doctor, because there are some treatments that can help you through that transition period.
One more thing, actually, I did not make it a question in the list, but it just came in my mind. PCOS. This is very common in girls, in young girls, polycystic ovary syndrome. So just tell something about that.
Yeah, so polycystic ovarian syndrome basically just describes what we would see. So it's basically a condition where the easiest way to explain it is if there's an imbalance in hormones. So when we look at for a woman to have a normal period every month, what needs to happen? She's got hormones that get released from her brain, which then stimulate her ovaries to work. Her ovaries start to make some hormones. They start getting ready to release an egg, and then that egg itself starts to make some hormones, and the lining builds up on the inside of the uterus. And if that, if that egg doesn't get fertilized that month, she'll have her period, and then the whole process will start again. So you can see there's lots of little steps there. If things aren't done at the right time, at the right dose or whatever, that the period could be off. And in PCOS, what happens is a little bit of imbalance in the hormones. And typically what will happen is women will not get their periods on a regular monthly basis. They'll often go maybe 2 months or 3 months or even longer without having a period. The other thing, because there's an imbalance in hormones, we can see things like maybe a little bit of increased hair growth, right? So that would be along the midline of the body. So any kind of hair growth that goes along the midline can be increased. And because women may not be ovulating, sometimes it can take them a little bit longer to sort of get pregnant as well. So PCOS just basically means, and then if we were to do an ultrasound, we might actually see evidence of where the body had started to maybe kind of get an egg ready to release, but didn't actually release it. And then it tried again next month. And so you get a very bumpy appearance to the ovaries when we take a look. And so that's what it means. Say poly means more than one, cis means little cis, ovary. So when on the ovaries, they look and they'll see a lot of little cysts on the ovaries. And so that's where they kind of got that name from. But again,
it can be treated. It can be treated.
Yeah, it can be treated. It really just depends on what the goals are. So the number one question is the patient with polycystic ovarian syndrome, is she wanting pregnancy at that time or not? Because that really changes how we sort of manage that. So that's the number one question. Oftentimes women with polycystic ovarian syndrome are very sensitive to weight. So when they're heavier and they've gained some weight, oftentimes their polycystic ovarian syndrome, the imbalances will act up a little bit again from that fat that I was talking about. So one of the ways that we manage it in a very simple way is just to, encourage the woman to lose some weight. And oftentimes that's all she needs to get her periods kind of coming back to normal again. But outside of that, there are some medical therapies that we can use just to help treat that. We do want a woman to be having a period every month, because if she's building up her lining for too long without shedding it, we know that over, years and years and years could maybe increase her risk of having cancer on the inside of the uterus. So for a woman with polycystic ovarian syndrome, from in my practice, it's really important that they bleed at least once every 3 months. So if they have not had a natural bleed, I'll often give them some medication to either to make them bleed, or we'll put them on, let's say, a medicated IUD to help keep that lining really trim, so they're not having to worry about this overgrowth that could happen.
And now my last question, as you are dealing with lots of South Asian community, from our community, do you think our women from South Asian communities, they are quite vigilant about all these diseases or issues that we talked about?
I think there's always a learning curve, right? I do feel like, perhaps women who come from, let's say, countries from India, they often haven't been taught this stuff in school, right? So I did notice when I was first starting to work with a lot of women, let's say from countries where they didn't have this kind of curriculum, and I would show them, pictures of their anatomy. I'd say, okay, well, here's your uterus, here's your fallopian tubes. And for a lot of them, I could tell it was the very first time they'd ever seen it, right? And so I think they were often getting educated through their mothers and their aunts, and some of those urban myths or those legends and stuff were kind of persisting a little bit. And so I would spend some time kind of correcting that. But I find that women, that when I talk to them and I show them these things, they're actually very interested, and they're like, they actually are very curious about their bodies and how they work and stuff. And so I think it's just a matter of having those conversations with them.
Yeah, because in those countries it's a kind of taboo to talk about these diseases, about women's body and everything. This is another thing.
Sexuality is a very taboo subject in a lot of sort of those Eastern kind of countries, where women aren't really allowed to be sexual or own their sexuality and stuff. It's somehow seen as a bad thing. I mean, I think that's changing with time. I think there's healthy sexuality. Sex is an important and natural part of our lives as humans, and certainly in relationships and stuff. And so, a healthy attitude from both partners and a healthy knowledge from both partners, I think, goes a really long way.
Yes. Now I want to ask you about yourself. What is, as you are a founder of Project Empower Her. So what is this?
So after all my work, Deepshika, I was talking a little bit about, some of the work that I do with birth control and stuff, and, how I have found, for me, when I see a lot of young women in my practice, or, even women, who might be married and stuff, that, like I said, birth control really changes lives, I feel like. And oftentimes women aren't all that well versed. Like if, like I said, during COVID, if 70% of the population was at risk of something, you think we would know a lot about it. And we would know, like even the men, like everybody would know about this. But yet, this is something that birth control is needed by 70% of the population. But yet, when I talk to a lot of men, like they've never been invited in on the conversation. So when I start talking about birth control with them, they're actually very, very interested in how it even works and what does it do. And oh my goodness, this is fascinating. So anyways, we started Project Empower in 2020 to try and improve awareness and access to long-acting birth control, because I think, when you look at a lot of women in poverty, the number one reason that women sort of stay in poverty is because of a lack of education. And when you look at, what is the reason they don't get educated, it is usually around reproductive health issues. So whether it's teen pregnancies that are happening in urban developed ghettos, or whether it's, child marriages that are happening in Bangladesh, it's because, these women under 20 are getting pregnant, and when they get pregnant, their future of education gets limited. And we know that, if you educate a boy, you will educate an individual. You educate a girl, and you will educate the next generation. And so for me, I think that's a really key way to break that cycle of poverty, is to make sure these girls get educated, and, and to make sure they don't get pregnant until they want to. And long-acting birth control is the best way to help them guarantee that. I find that a lot of women who live vulnerable lives, their life experience is life happens to me. I don't get to choose what happens to me. And often for them, a real reality is pregnancy is something that just happens to me. I don't get to choose it. But when I talk to them, I say, no, you know what? You can choose. When do you want to be pregnant? And if you're telling me you don't want to be pregnant until, if you're a 16-year-old, let's say, and you're telling me you don't want to be pregnant until you're 20 or 21 or into your late 20s, here is something that I can give you that will give you a 99% success rate. And it's the first time for a lot of these women where they've actually been able to really think about, oh, I set a goal, and now here I have been given a 99% chance that I'm going to reach it. And then I start to see something shift in their thinking, because now they start to think about, well, what else can I do? Can I finish school? Can I go, further in education? Could I develop a career? And I've seen this happen time and time again. And so I don't want women and girls to be left out of this conversation. So I want people to be making, to me, it doesn't matter to me what women choose in the end for birth control, but I want to make sure they have all of the information before they decide, that they're just not thinking, well, I don't have any options, I can't use this, and maybe they don't know about all of their options. Maybe they don't know about the effectiveness rates. So Project Empower, we've started. I did a TEDx Calgary event that was virtual, so that will be online shortly. And we're hoping to change public policy as well, right? That these methods of birth control should be covered by the public purse, because it costs us money. If a woman decides to have an abortion, that costs, the government a lot of money. And if she chooses to have that baby and now she's on social assistance, that cost is going to be phenomenal as well. So really it's about women sort of leading empowered lives. And when a woman leads an empowered life, she gives birth to empowered children. And that's how we lead ourselves to an empowered society. I think women are one of the most underutilized but most powerful natural resources that are available to us. And you look at societies that are doing well, you will find women that are doing well. You look at societies that are struggling, you will see women that are struggling. And so I really think that is one of the key things. It's a very simple solution to very complex problems in life, but sometimes, like I said, it's not so much new innovations that will change things. It's a new way of looking at it that changes it, right? So for me, I always think of birth control as a tool of empowerment. It's not about having sex, who and when you want to have sex with, that is a conversation best had in families. I don't even come into that conversation. But my thing is, if you're having sex and not wanting to get pregnant, let me help you to make sure you don't get pregnant until you actually want to be, because I don't want that to be something that changes your life in a long-term way.
And are you holding some seminars or anything for Project Empower?
So unfortunately, when we started Project Empower in January 2020, we had no idea this pandemic was on its way, and we had to kind of put things on a little bit of a pause.
Right. But it's in the pipeline.
Yeah. So now we are sort of, thinking about the things that we can at least start to work on, and so obviously because we've gone to a virtual world, we will be looking at sort of doing some maybe information videos that we could put online for patients or for women themselves. And then even training doctors. A lot of doctors maybe aren't that familiar with long-acting forms of birth control. So an education mandate is really, really important to us. So that's the awareness piece. And then the access piece was, once you know what you want, what are the blocks that are stopping you from getting it? So whether it's access to the procedure, so again, maybe training physicians, all over, the province, the country, the world, to kind of, do these types of procedures. But sometimes there's financial barriers, and that's where we really want to affect some policy change, so that, women, like Deepshika, the other day, I had a young girl, she was 22. She was working in retail. She didn't have any coverage because, she was not 21 anymore. So no insurance coverage for her medications. And she really didn't want to be pregnant. She goes, but she couldn't afford an IUD, and it's $350. And I thought, well, you can't afford to have a baby either, right? And so what does she do, right? And so, you know, we luckily we can sort of get access to some, you know, donated IUDs and stuff. But, you know, if financial barriers, you know, we don't want that to be sort of a barrier. So we really do feel like, and we know that there is going to be a cost savings if the government were to step up and cover maybe at least 25 and under long-acting forms of birth control for those types of women.
Thanks, Dr. Toor. It was really very informative talk with you, and I would like to invite you again when you will start your women, your project empowerment. You know, really in out of this COVID period, you will start that. So thanks a lot. Thanks for being with us. It was amazing time with you.
Yes, thank you, Deepshika. You are one fantastic example of an empowered woman who has taken, you know, your gift in media to use that as an educational sort of platform so that all women everywhere can sort of benefit. So thank you for having me on.
Thanks a lot. You have a good night.
Bye.
Bye. Yes, guys, this was Dr. Rupinder Toor, and we had a very detailed talk with her. And I really believe in that women need to take over the control of their health, especially in the area of family planning. Women should be empowered to speak on when and when not to have a baby. Moreover, it's their own body. And this is empowerment. So nice to be with you today, and I'll talk to you later, and I'll come with another personality in a podcast. Until then, ciao.